Thank you so much for being here. It's really an honor for me to be here with such an esteemed panel of presenters. And it really is an honor for me. Just a little bit of additional background in terms of my regenerative medicine experience. In 2007, I was the first physician in New England to do PRP treatments. 2008, I was the first physician in all of New England to do bone marrow aspiration treatments for orthopedic conditions. And in 2009, I was the first physician in all of New England to start doing lipoaspiration for orthopedic regenerative medicine procedures. So I'm bringing a lot of background and experience to today's meeting from the musculoskeletal side of things, and we're going to be talking about that a little bit later in the meeting. Today, and for this morning's talk, I want to take a step back and say, what is this stuff that we're using? Everybody's talking about adipose, but what's in this? What's the biological basis for why we're using this and why we want to use it? So I have no financial disclosures. Any mention of any products is merely for demonstration purposes. So let's look at the basic structure of adipose. And here's a colored micrograph. And you can see some of the ultra-structural features of that. The large bulbous structures are the adipocytes, the fat cells themselves. You see the connective tissue matrix, which is the extracellular matrix. Looks like a very fine fishnet surrounding it. You have the capillaries with the pericytes, which we're going to talk about in a moment. In the extracellular matrix is embedded the mesenchymal stem cells. And then you see another type of cell population called the progenitor cells. What's the difference between a mesenchymal cell and a progenitor cell? Think of a progenitor cell as a stem cell that's halfway in between being a stem cell and being a fully differentiated cell. So a stem cell itself has almost an indefinite capacity for regeneration. A progenitor cell is already moving in the direction of target tissue. It just needs a little push to get there. So some people will use the term progenitor cell and mesenchymal stem cell interchangeably. They're really not. They're just a degree of variation along the line of differentiation. And that's important for something we're going to get to in just a moment. If we look at the actual cellular composition of that, the adipocytes themselves, even though they make up the largest volume of the adipose, they only make up 16% of the total cell population. So that's important to understand. 30% of the cells are actually the progenitor and stem cells. So you actually have far more stem cells than you do actual adipocytes in a given volume of adipose. And then you've got the endothelial cells, fibroblasts, smooth muscle, leukocytes. So very, very rich, biologically active, cell-rich population in a cluster of adipose that you harvest. Continuing to look at the adipose contents, you have the mature adipocytes, you've got the extracellular matrix, and then you've got the blood. Of the blood component, after that, everything else can be considered what's known as the stromal vascular fraction. So once you get rid of the adipocytes, once you get rid of the blood and the extracellular matrix, you basically can think of everything that remains as being the stromal vascular fraction. And that is what contains all of your bioactive cellular populations, as you can see on the slide. The term SVF, or the concept of SVF, was actually discovered back in 1964 through some enzymatic digestion. And then it was Patricia Zuck back in 2001 who actually identified the multipotent potential of the cells contained within the SVF. Zuck referred to these multipotent cells as being processed lipoaspirate. Now we're going to talk a little bit about nomenclature. It gets a little confusing. In my world, the musculoskeletal world, we refer to PLA as the processed fat, what you would talk about as being the microfat, nanofat, so on and so forth. In our musculoskeletal world, we refer to that as PLA, but Zuck actually referred to the cells themselves as being the processed lipoaspirate. This is where the nomenclature gets a little bit confusing here. So some researchers refer to the stromal cells as the SVF. Some are referring only to the regenerative cells, which means you're excluding the leukocytes and the epithelial cells and endothelial cells as SVF. Some are referring to the mesenchymal stem cells as SVF. But if you look at the International Fat Applied Technology Society, IFATs, they are referring to the adipose-derived stem cells as ASCs. And they say do not confuse those with SVF. Most of the time in the research, when you see the term SVF, that's referring to a specific substance that has been obtained from enzymatic digestion of the fat, and they've collected and harvested the cell population. That's distinct from the stem cells themselves from that population. So it can get a little confusing, but any time in research that you see a paper that's looking at the effect of adipose-derived stem cells, they're almost always talking about culture-expanded cells. And so you got to be careful about the technology and the terminology when you're reading the research. So when we think of processed lipoaspirate, it can refer to the SVF. It can also refer to the intact micronized fat, but it does not refer to the isolated stem cells themselves. So make sure that you understand the distinction between the term ADSCs, or fat-derived mesenchymal stem cells, versus SVF and PLA. They're not the same thing. Okay? And by the way, you'll get copies of all of these slides. So now let's talk a little bit about the adipose-derived stem cells themselves. They do have a multilineage differentiation compatibility or capability, and you can see that in the slide there. And Zuck again was one of the ones who identified this multilineage capability. So there's a lot of bioactive potential in these adipose-derived stem cells. A lot of the bioactive or regenerative cells are these pericytes or perivascular cells, and you can see them on the slide highlighted. These are cells that cling to the microvasculature within the fat. And I've got another slide, and you can see them all. They're those little pods that are wrapping around the microcirculatory system. And these are actually regenerative cells. Arnold Kaplan, who's a PhD and one of the fathers of mesenchymal stem cell biology, has postulated that the pericytes are actually activated mesenchymal stem cells, that these pericytes reside on the microvascular circulation. Once they get triggered, either by some type of injury or some type of stimulation, they then morph into an activated mesenchymal stem cell and then enter and exert their bioactive effect at the wound site. I don't think that's quite accurate. I found enough research that says, yes, that does happen. Kaplan is saying that's the only thing that happens. But there is enough research that shows that when you inject mesenchymal stem cells into tissue or into a joint, about 1 to 5% of those injected cells themselves will undergo differentiation. The rest of those cells will act as signaling cells to trigger this perivascular activation. Kaplan goes on to say that he thinks MSCs should not be called mesenchymal stem cells. He says they should be called medicinal signaling cells. And to a large degree, I agree with him, but there is a portion of the mesenchymal stem cell population that itself will undergo terminal differentiation. So we just have to be careful not to lump everything all into one basket. This is a really, really neat slide, and if you can go ahead and trigger the video, this is a wound in the epithelium of a zebrafish, and down below you're going to see the microcirculatory capillary, and as the video plays, you're going to see these perivascular cells peel off the vasculature in this time-lapse electron micrograph, and you can see them migrating up towards the wound. It's a really, really cool video that gives us an idea of what's happening biologically when these cells get activated and migrate up to heal an injury. And in our world, at least in the musculoskeletal and to a certain degree in the plastic world, we're trying to stimulate a healing and repair response. This is part of what's happening at that level. Let's take a look very quickly at the difference between adipose and bone marrow. I do both. I do bone marrow harvesting and I do adipose, and the reasons why we're not going to get into here. But let's take a look at the different populations here. If you take a volume of adipose, and in this case we're going to compare a gram of adipose, that's going to contain between 5 and 10 million total nucleated cells. TNCs are total nucleated cells. Of those TNCs, 50 to 80% of those are going to be stromal vascular fraction cells. If you remember from a previous slide, that includes everything that's not included in the extracellular matrix and the blood, okay? Of the stromal vascular cells, the stem cells themselves represent between 1 and 10%, and Fraser has said it's really about an average of 3% of the total nucleated cells in the stromal vascular fraction are actual stem cells, okay? Therefore, you're going to get between 5,000 and 200,000 adipose-derived stem cells from a gram or milliliter of processed adipose. Let's look at the bone marrow side. If you take an equivalent volume of bone marrow, which is going to be 1 ml, you are going to get more total nucleated cells, roughly between 6 and 10 million. However, only 0.1 to 0.001 are actually considered a stem or progenitor cell. That's an incredibly small number of mesenchymal cells per unit compared to what you get in the adipose. So if you take an ml of processed adipose, you're going to get between 5,000 and 200,000 stem cells. If you take the same volume of bone marrow, you're going to get between 60 and 600 cells. Tremendous difference between the two. If you look at peripheral blood, by the way, by comparison, there's almost none. They are in there, but it's absolutely not a good source for these regenerative cells. So now, if you compare, 100 mLs of bone marrow and 100 grams of adipose, you're going to get between 300 and 500 times more stem cell yield from the equivalent amount of fat than you are from bone marrow. Let's look at the effect of aging on our stem cell population. In the bone marrow, the stem cell population falls off the cliff in a logarithmic fashion. It doesn't happen in a linear fashion. It happens logarithmically. So you can see when we're a newborn, we've got the highest population of stem cells in the bone marrow. By the time we're 80 years old, that little number in brackets, that's two. That's 2 stem cells per 100,000 marrow cells. So it really falls way, way off the cliff as we age. What's neat is that doesn't happen in adipose. So this is a study that was done where they took donors, and how they ended up doing this, I don't know. They had 27 donors between less than 1 year old, 50 donors that were under 12 years old, and they harvested the adipose and they looked at the stem cell characteristics. And what they found was both in vitro and in vivo, the properties were similar and maintained during aging. All right, well, great. You're talking about a population that's less than 12 years old. How much aging occurs between 0 and 12? Not much. We'll talk a little bit about that in the next slide. What I wanted to show you next is the multi-lineage capability of adipose-derived stem cells. And here on the left-hand side, these are all the studies listed that I could find. On the left-hand side, you see it's all adipose tissue. The center is the musculoskeletal applications. The right-hand side are the references. And I've highlighted all of the multi-differentiation capacities of the adipose. And you can see hyaline-like cartilage, bone tissue engineering, tendon tissues, vascularized tendon, hyaline cartilage, soft tissue cartilages, bone formation. An incredible variety of regenerative capability out of the adipose-derived stem cells. Okay? And Burroughs went on to say that based on all of this, we're suggesting that the adipose-derived stem cells may actually be the better source for musculoskeletal tissue engineering compared to bone marrow due to the limited loss of differentiation potential as we age and because of their ability to undergo that differentiation. Okay? In vitro, in the lab, bone marrow does show a higher potential towards chondrogenic and osteogenic differentiation. But keep in mind, that's in the lab. What happens in the body may not be the same thing. Adipose cells in the lab show more effective collagen production. So what you'll see in the clinical world is if it's a tendon or a ligament, or in the case of adipose, tissue, soft tissue, people are using more adipose. In the case of cartilage and bone, people are using more bone marrow. But they're basing that on what happens in the lab. What happens in vivo may not be the same thing. We get great results using bone marrow in soft tissue. We get great results using adipose in the joint. So I'm not sure that all of this shakes out in the clinical world. I'm just showing you what they're saying in the science world, okay? For the sake of time, we'll move on a little bit. Looking at adipose versus bone marrow, these were 9 donors between 8 and 14. This study did show that the bone marrow had better osteogenic and chondrogenic, but the adipose had better myogenic, so that's muscle, neurogenic, adipogenic potential. And so really, really great opportunities. So adipose is highly accessible. In the workshop yesterday, we showed you how easy it is to harvest the adipose. It is ripe with lots of regenerative capacity along multilineage lines. They do appear to be superior to bone marrow in many respects, and I put in italics, maybe osteogenic and chondrogenic. But I know docs who are injecting processed adipose into bone marrow lesions and osteonecrotic lesions and getting great results. So again, I'm not sure that what happens in vivo is what we're seeing in vitro, okay? Details matter, and I think this is really important. Garbage out, garbage in. If you don't have good harvesting techniques, if you're not processing the tissue properly, and particularly if you're not injecting it properly, you're not going to get good results. I had a patient that I saw a few months ago. He had bilateral ankle osteoarthritis, and he told me he had 2 corticosteroid injections done into his ankle under ultrasound guidance, and they didn't give him any relief at all. And I know this sounds kind of arrogant, but my first thought when I hear that story is, even though the doc used ultrasound, he or she still didn't get it into the right place and didn't know what he or she was doing. I convinced the patient to let me try one more time. I said, you know, I've been doing ultrasound a long time. I teach ultrasound. Let me give it another go. He said, sure, doc, you know, whatever. He was a great guy. Did an injection under ultrasound guidance. He emailed me the next day, doc, I had 100% pain relief. It makes a difference if you get this in the right spot. And we see docs who put an ultrasound probe on the skin, they do a blind injection and bill it as an ultrasound-guided injection, and they have no idea where that needle is going. The patients come to us and they say, well, I had a PRP injection and it didn't work, or I had a lipoaspiration procedure and it didn't work. Well, my first thought is, it didn't get in the right spot and it wasn't done properly. The details matter. That's why you're here, to learn the right way to do some of these things and hopefully have much more accuracy and better results moving forward. Thank you.